Hello guys. So earlier on we did cholecystitis. So we are continuing with our series on biliary tree pathologies. So let's try and put everything in one page, and so that we can know where we are and where we're going. So we all know this structure by now. This is our pancreas. Pancreas with pancreatic duct, common bile duct, a cystic duct, gallbladder, common hepatic, left hepatic, right hepatic. So we spoke about a situation whereby we've got stones that are just sitting here in the gallbladder, and we said that that's choledocholithiasis on our previous videos. Choledocholithiasis. And we said that those stones, they just sit there. If they continue to sit there, they won't bring the patient to the hospital because they will be asymptomatic. There won't be any symptoms, but they can happen to be an incidental finding. If there is one slide, let me call it a slide, that you guys have to capture, is this one on the biliary pathologies, especially those that has got gallstone involved, because we're still going to talk about cholangiocarcinomas and other malignancies of the biliary tree, but right now we're talking about this. So these patients will be asymptomatic, like we said. It can be an incidental finding, either intra-op, when a patient was being operated for something else, then they find it, or someone was doing an abdominal ultrasound looking for something else, and then they find it. That's incidental. Or the patient can be symptomatic, and we said that once a patient becomes symptomatic from choledocholithiasis, it's now called gallstone disease. And when does that happen? Gallstone disease. Go back to the very first choledocholithiasis video and watch. We explained this in detail. But basically, someone who gets a stone that sits here, and then it's like sort of like it sits there at the mouth, and then it has got a chance of coming back and rejoin the other stones. So the symptoms are on and off, but that's the first area. But if the stone comes and sit here, a patient, this stone cannot come back and rejoin this stone. It's stuck there. Then this patient will develop, because of, go and watch again cholecystitis video. So the patient will get cholecystitis. And then if this stone happens to be so big that it compresses on this common hepatic duct, that's called Mirizi syndrome, or Mirizi syndrome. So this patient is going to present like a patient who's got choledocholithiasis, which we're going to talk about. So it's Mirizi, this is an R. So a Mirizi syndrome is a stone that is in the cystic duct but compresses the common hepatic duct. That's a Mirizi syndrome. But if the stone manages to pass and then get stuck here in the common bile duct, then that's called choledocholithiasis. Choledocholithiasis. We are going to talk about these choledocholithiasis. We are going to talk about the complications of choledocholithiasis, which are acute cholangitis, and gallstone pancreatitis. Okay, so that's when now you've got a stone somewhere here. When you've got a stone here, it means the pancreatic juice and the enzymes won't make it to the duodenum because of this obstruction. So the enzymes that are secreted by the Acini cells into the duct, those enzymes are normally inactivated, but the longer they stay there because of the stasis, they start to be activated, and then they start to digest the pancreas. And this patient will have a high lipase and a high amylase. We're going to talk about those things. So that's what is called gallstone pancreatitis. Now, if you have a situation whereby this stone manages to, let's say we've got our small intestine like that. So if any of these stones can manage to, let's say this same stone manages to get inside here through a fistula. This fistula is normally called a biliary enteric fistula. Biliary enteric fistula. So if that stone manages to get inside here and for some reason gets stuck at the small intestine, the ileum, that's called Gallstone Ileus. So this stone is gonna get stuck. Remember the parts of the way I remember them, it's DJI, duodenum, jejunum, and ileum. So if this stone gets down, travels, and then gets stuck here and cause intestinal obstruction, that's called Gallstone Ileus. So it's like a bowel obstruction kind of. So guys, these are very important. Choledocholithiasis, gallstone disease, cholecystitis, Meniere's syndrome, choledocholithiasis with acute cholangitis, gallstone pancreatitis, gallstone ileus. So basically we have covered a lot in one page. So now we are going to talk about each and every one specifically. We've done this and cholecystitis. There isn't much there, but we are going to talk about it briefly. But we're going to talk about this is very important because a patient that is going to die because of biliary obstruction, they will die because they developed acute cholangitis. It's so important. We are going to talk about it now. Okay. So let's check my time there. Okay. Okay. So let's quickly draw again. If there is one structure that I'm confident drawing in the body, is the liver and the biliary tree. Okay, it's one thing that I can confidently draw. Okay guys, this is drawn out of scale. Like I always say, remember that the gallbladder is stuck on the undersurface of the right lobe. There's even an indentation or an imprint of the gallbladder. That's how close it is there. So I've just pulled it so that we can see what we are talking about. So now we say we've got a stone that managed to live here, got past here, but got stuck here. What is that? That's choledocholithiasis. A patient who's got that, how will they present? So basically it's just an obstruction. As we all know that once you obstruct here, the drainage will keep coming from the gallbladder, from the liver itself, and then this will dilate to try and accommodate. But it's going to get to a point whereby, so there's going to be stasis, but it's going to get to a point whereby it cannot dilate anymore. So you're going to have the stasis is going to now affect the cystic duct, affect the common hepatic, and all of just like that. So you're going to have stasis here, stasis, and this stasis. So the picture that you're going to get, because it's going to be obstructive jaundice in a way, because you don't have anything that is draining. It's going to be obstructive jaundice. So your patient will present with jaundice. Patient will have jaundice. So guys, they will present with the right upper quadrant pain, right? They will present with nausea, they will present with vomiting, they will present with diaphoresis, they will present with anorexia, which are all non-specific symptoms. But something special is happening here. We haven't mentioned jaundice when we spoke about choledocholithiasis. We didn't mention jaundice when we spoke about cholecystitis. So what differentiates those three is this guy, the jaundice. And these patients, they should come back, they should come in stable. They'll just have that pain and that jaundice that they are having. But the jaundice in them is going to be the one that's going to pull you to want to investigate this patient. If you have watched our approach to LFTs, you will be able to differentiate a medical jaundice from a surgical jaundice. This will come in as a surgical jaundice because this is obstructive jaundice that they're going to be having. There's an obstruction, so it's going to be obstructive jaundice or post-hepatic jaundice or a surgical jaundice. So which means that, okay, their vital signs should be normal if they don't have a complication, which we're going to talk about. They should come with normal vital signs. They should come in with abdominal examination should also be fairly normal, but it's just that the things that are going to be positive that are going to find, they might have tenderness on the right upper quadrant, right upper quadrant, but not a Murphy sign. They won't have a Murphy sign. They won't have a mess there even. So they will have jaundice. They might have cold-colored urine because it's obstructive jaundice. They might complain of, or they will complain about itching, cold-colored urine, pale stools, and that kind of, features of obstructive jaundice. But after that, you will do your bloods. As you do your bloods, you will find that they've got a normal white cell count, because choledocholithiasis is not an infective or inflammatory process, so you shouldn't have a white cell count that is high. But if you have, something else is happening. And then also the CRP should also be fine, should have a normal CRP, but then they will have a high ALP, they will have a high GGT, because these are features of obstructive jaundice. They might have elevated ALT, and AST. And remember, I would really, guys, recommend that you go and watch the video approach to LFTs, because if you've got all of these high, how do you say it's medical jaundice, or how do you say it's surgical jaundice, or how do you say it's intrahepatic jaundice or post-hepatic? I've explained those in that video. But basically, in this case, these ones are gonna be like very high compared to these ones. These ones will be high, but slightly, even though they will be high, but they won't be, the ones that are gonna be mainly high are these two guys as a sign of obstructive jaundice. Then you're gonna have a high bili as well, high bilirubin. So that's your choledocholithiasis. It's okay, it's beautiful, it's fine. But when you've got a patient who's got an obstructive jaundice, you cannot not rule out acute cholangitis. It's like when you refer a patient to, when you discuss a patient with a surgeon who's got obstructive jaundice based on your clinical findings. One thing that they will ask you is how stable is the patient, and one of the things that will make a patient who's got obstructive jaundice to be unstable is acute cholangitis. And what is acute cholangitis? Some people call it ascending cholangitis. Sorry. So basically what happens with acute cholangitis is that the ascending part is nice because it helps you to understand what we are talking about. So basically, like we said, that we have got our pancreas there, we've got our opening there, and this is our duodenum. So we've got bacteria, as we all know that the GIT is not sterile. So we've got bacteria like E. coli, and yeah. So those bacteria, because there is no remember, when bacteria try, just like the urethra, when bacteria are trying to climb here, go up and go up, if you continuously have bile that moves there, you will be able to wash them out. Every time they try to climb, you will wash them out. But in this case, we've got obstruction, so we cannot wash them out. So these bacteria, they keep going and going and going and going. So they are ascending. So they ascend and then they join this stasis there. And then remember, whatever that is stasis is prone to have bacterial proliferation. So they join here, these bacteria, they join there, and then now they cause infection. So now a patient now comes in with fever. All of a sudden they've got fever. All of a sudden they've got an increased white cell count. All of a sudden they've got an increased CRP. When you've got this, you no longer have that, you have this guy. So when it comes to, okay, so now this patient will have jaundice, because remember, we are coming from there. This patient will have jaundice. On top of the jaundice, they will have a right upper quadrant pain, which is something that we also have here. Because remember, this acute cholangitis is a complication of choledocholithiasis. So, but now the difference is that you also have fever here because of this. Because now it's an infective process. These three are called Charcot's triad. Charcot's triad. Charcot's triad. And if things are horrible, like are going very bad, you might also have hypotension. Hypotension plus altered mental status. And these now become 5. 1, 2, 3, 4, 5. And when they are 5 like that, they are called Raynaud's pentad. Raynaud's pentad. So remember these guys. When you know these things, they always make you look smart. Okay. So that's what so now you've got a complication of choledocholithiasis. Choledocholithiasis. So let's talk about, because it's also important, let's talk about this. So we are coming from here, from this guy, and now we are here. So let's talk about the management of this. This patient is sick, will need to be stabilized. And the fact that you've got hypotension, this hypotension can be caused by two things. It might be septic shock that the patient is developing, very sick patient, or it might be that we are starting to have multi-organ dysfunction. One of the ways to see whether you've got multi-organ dysfunction, and specifically you are having a dysfunctioning heart, is hypotension. The heart will give you hypotension, and such that your patient will need to be on positive inotropes to keep a good cardiac output. because basically they are going to go into, because remember, once you go into what's this thing, once you go into cardiogenic shock, then it means you'll not be perfuse your organs, and your organs are going to die because of hypoperfusion, which will cause ischemia, and you don't want that. And the fact that now you've got also mental state, altered mental status, it could be that this is very septic, and maybe now you are having involvement of your brain as well. So this is a very sick patient. You don't want to get here. You don't want to get here. This is like clear ICU patient. So when you've got an obstructive jaundice patient and then you present to the surgeon, they can say, okay, send the patient next week or to the clinic. But once you mention this, they will say send the patient now. So that's how important acute cholangitis is. And it's important when you call someone and say, doc, I've got a patient that is presenting with signs and symptoms of obstructive jaundice, but however, they don't have any features of acute cholangitis at this point, because you would have taken your bloods, checked their temperature. Remember, fever is a temperature of more than 38 degrees. So the management here would be to, if this patient were to come to me, one, let's talk about the patient who's not hypotensive or whatever. So what I'm going to do for this patient, definitely, I'll give this patient oxygen. Number two, I'll put IV line on this patient. I will start this patient on a broad spectrum antibiotics, preferably maybe augmentin or maybe ceftriaxone. I will put a catheter on this patient to monitor output. I will, because I'm going to be giving fluids. I don't want this patient to go into shock, so I want to give them that. And I will take a blood culture on this patient. I will obviously I would have taken these other bloods, the CRP, white cell count, all those things, and I'll try and transfer this patient. It's always nice when you call someone, even though you ask someone, okay, doc, I've got this patient and then they accept the patient. Okay, you can send the patient. It's important to ask, what do you want me to do for this patient before they leave, so that you do exactly what they want you to do. So this patient needs to go, because this patient needs urgent ERCP. Urgent ERCP. Okay, definitely, if you've got a patient like this, you do an ultrasound if you have got the resources, but this is more like a clinical diagnosis, guys. The person who's gonna need imaging is the person who's gonna be managing this patient. Personally, as a GP, if I can pick this, I can see the symptoms of features of obstructive jaundice, and then I see that the patient has got acute cholangitis. I've done my job. So it's for them to see where is the obstruction, because so, but ultrasound will tell you where the stone is, and also you will see a dilated CBD of more than 7 millimeters. Yeah, so you can see a stone, or you can just see dilatation. The minute you see dilatation, especially it's going to be a proximal dilatation, because if the obstruction is here, then it might be proximal dilatation. And you know what they normally show, what do they call this thing? A big sign in esophagus, a big sign. It's going to be something like a big sign as well. But the difference here, you have not swallowed a bottom swallow. So you're going to see something like this. So this is proximal dilatation. So it means the obstruction is here. So you can even see a stone on an ultrasound, or you can even do a CT or an MRI. So what is the management for this? Emergency management, ERCP. You must go and Google ERCP, guys, how it's done and all of that. But basically, this thing is both therapeutic and diagnostic. Another option is what they call lithotripsy. Litho means stone, tripsy means to break. So lithotripsy. And there's also what they call a transhepatic biliary drainage. Yeah. So those are the options for for management of choledocholithiasis or acute cholangitis. Choledocholithiasis is also, it needs to be managed, but the management is not different from this, but just that now it's not an emergency, but you don't want to start to want to pay attention to this patient once they develop acute cholangitis. You want to treat them while they still have choledocholithiasis. While I'm still at it, you can have acute cholangitis without choledocholithiasis, because anything that can cause obstruction here, even if it's malignancy, the patient will have acute cholangitis. So guys, for those who want distinctions, you can go and read extensively about lithotripsy, but it's basically just shock waves but it's done in theater under anesthesia. The shock waves, they break the stones and then they're able to pass. So they're different. We can also go and read about ERCP extensively, but we are not specialists. Once we get here, we as GPs, we are okay. So I think that's it with acute cholangitis and choledocholithiasis. So in our next video, we're going to talk briefly about Meridzi syndrome and Gallstone Ileus, and another complication of choledocholithiasis, gallstone pancreatitis. We have to talk about it. Okay, thank you so much, guys, and enjoy your evening. Let me go and sleep now. Bye.